can get started. All right. Well, first of all, welcome everybody, our participants, and especially our panelists. Thank you for joining us for the first in a series of webinars on behalf of the Youth Health Forum's Youth Leadership Group. I'm really excited to have everybody here today and introduce you to the experts in the field of health policy. My name is Georgia. I'll be hosting and moderating the chat today. First of all, I'd like to begin with acknowledging the traditional owners of the lands in which we're all joining this meeting from. For myself in Western Melbourne, that's the Wurundjeri Woi-wurrung and Bunurong peoples of the Kulin Nation. I would like to pay respect to the elders past, present and emerging and acknowledge that the sovereignty was never ceded. So this webinar is the first in a series being put together by CHF's Youth Health Forum. The webinars will explore 4 topics selected by the Youth Health Forum that are of particular relevance to young health advocates interested in improving health systems and championing their causes. Many of the topics are areas that our own young advocates wish that we had known more about when we'd first started our own advocacy journeys. Today, we're going to be talking about health policy. So you can consider this a bit of a crash course in how, where and why health policy decisions are made and how you can get involved in that process. We know from experience that health ministers and funding schemes like the NDIS can be a bit of a maze. There are many different departments, ministers, peak bodies, and a huge amount of funding that's covered by these systems. The aim of this webinar is to help you better understand how the systems work so you can feel more confident talking about issues and solutions when you're in a room with policy experts and health professionals. We've already received some really great questions in advance of the presentations today. This will be a nice and interactive webinar, and we have lots of time for questions with our expert speakers. I really encourage you to post your questions in the chat as we go. Myself and Carolyn, who's our wonderful policy officer from CHF, will be moderating the chat as we go through the webinar and presenting our questions to the experts at the end. Any sources or slides or supplementary resource materials that we're able to share after the webinar will be made available to you. So we're going to start with a little bit about the background of the Youth Health Forum, and then we'll jump right in to getting to meet our experts. So for those of you who aren't too familiar with the Consumers Health Forum, they are the national peak body for Australian healthcare users. The CHF plays a really important role in connecting health communities, patients, carers, and people with lived experience with the policymakers, peak bodies, and healthcare system decision makers in a meaningful partnership. They're a member organisation, and this includes peak bodies and organisations linked with specific diseases and individual advocates. CHF is a small not-for-profit organisation whose key strategic focus is to advocate by bringing consumer insights and perspectives to the national agenda. The Youth Health Forum was launched in 2018 by CHF to increase the youth representation in advocacy spaces and to better represent diverse health users. The Youth Health Forum members are aged 18 to 30 from across Australia with really diverse backgrounds and identities and lived experiences. There's a wide range of knowledge about health services, involvement with non-government organisations in the community sector, and engagement in local causes. The Youth Health Forum has been funded by the Commonwealth to provide advice and leadership in youth health policy and to equip young people with advocacy skills and knowledge to be meaningfully involved in discussions about our future. As I mentioned at the start, my name is Georgia. I'm one of the young leaders who support the Youth Health Forum in projects like this webinar series. I've been involved in youth health promotion since I was a teenager, specifically related to chronic rare diseases and peer-based mental health support. As well as my young leader role, I'm also the secretary with the Australia Alopecia Areata Foundation. I'm studying a graduate diploma in psychology, and I'm involved in some other CHF programs. I just want to say also a special thank you to our partners, Origin, Revolution in Mind, who have generously supported CHF young leaders to design and deliver this webinar series. We really appreciate Origin's ongoing investment in young leaders and advocates, their commitment to meaningful co-design with young people across evidence-based research and policy development, and acknowledge the high standard that Origin set for organisations working with young people. So with all of that background out of the way, I'd like to introduce our first speaker, Jennifer Doggett, who is a health policy analyst and consultant. Jennifer has worked in a number of areas in health policy, from being a political advisor in the Federal Health Department and in the community sector. She was the chair of the Australian Healthcare Reform Alliance for 4 years, where she successfully united different perspectives into clear messaging to advocate for improvements in the healthcare system. Jennifer is also the editor for Croaky, an independent social journalism project that enables debate and investigations of healthcare issues and policy. She has a lot of interest in addressing some of the issues about equity of access and fair payment systems for health consumers. With that, thank you, Jennifer, for joining us today, and I'll hand over to you.
Thanks, Georgia, and welcome everyone. It's lovely to, if not see you, then feel your presence through the ether. I'm really happy to talk to you today about something I'm really passionate about, which is engaging more people, and particularly people that are often unrepresented in advocacy in health system reform. I'll just share my screen because I've got some slides here for you. Here we go. Now, hopefully that will make sense. So what I'm going to do today, oh, sorry, I also forgot I should acknowledge the traditional owners. I'm speaking to you today from Ngunnawal country, and I'd like to acknowledge their elders, past, present and emerging, and particularly welcome any Indigenous people who are participating today. Here we go. So a brief overview of the Australian health system. Now, what do we mean when we're talking about the health system? It might seem obvious, but often what we're talking about is actually some quite different components of what goes together to make up our health system. And they include things like health services, health workforce, funding mechanisms, the way we pay for health services, health programs, and then health policies, which is like an overarching framework of how those things all fit together. Now, so I think just to set the scene and just to put a few caveats in place, I think it's really important to acknowledge that most of the factors that influence health are not actually part of the health system. So healthcare is obviously important, it is one component, but I think it's really important to remember that things like food, housing, relationships, poverty, income, employment, all those social determinants actually have a greater impact on people's health than actual healthcare. And I also think it's important to understand as advocates, because this is something that I've come up against myself, is the way that healthcare is organised and provided is often organised around the interests of providers and funders, and it doesn't necessarily reflect consumer experience. And I'm sure that's something those of you who have been consumers in the health system would have experienced. So often there can be a mismatch between the language that's used to talk about healthcare, the way that it's organised, and what a lived experience of a consumer is. And I think as advocates, often you'll have to become almost sort of bilingual in speaking the language of healthcare providers and the health system, but also understanding and maintaining your sense of what makes sense to you and your experience as a consumer, and understand that a lot of these systems have been put in place not based in consumer experience, but in provider experience. Now, let's see, here we go. Now, I also want to give you some of the reasons why healthcare is funded and organised the way it is. And this was a question I think that came from some of the participants today. And unfortunately, consumer interests and meeting consumer needs is often a really low priority when it comes to making decisions about why healthcare is funded and organised the way it is. It's often because of historical reasons. That's the way it's always been done. It's very often because it suits healthcare providers. It reflects the self-interest of particular narrow professional groups. It can be because of pressure from industry or other powerful stakeholder groups who are almost always not consumers. It can be because something has been featured in the media, or there's some pressure exerted from the media on a particular area. Often it's to do with the way the budgets are structured in terms of portfolio structures, administrative systems, the way that the budget cycle and the timeframes within which you want to allocate money and see where it goes and make sure that it's been accrued. Often governments can be quite risk averse and there can be quite a lot of inertia in that taking a risk to change something is often seen as more risky as continuing something that isn't working. Often it can be to do with our short-term political cycle to try and meet an objective to achieve something within a short-term time frame at the expense of some longer-term outcomes. And unfortunately, what's best for consumers often comes at the bottom of that list. So if you've ever had experience of a healthcare system or had some experience of healthcare which doesn't seem to meet your needs or the needs of consumers, you are probably correct. It's not that yeah, and these are some of the reasons why, because it hasn't been designed to meet consumers' needs, unfortunately. And this is one example, I think, of that. So I think there was a question about primary, secondary and tertiary care, which are terms that are used to describe different types of healthcare. And I've given a brief table here. So primary care, usually first contact services, so that the services that people access when they first have a problem, usually located in the community. Some examples, are a GP, also some allied health, dentists, that sort of thing, that the people that you can go to without needing a referral. Secondary care usually refers to services that are provided on referral, but often not in an institutional setting, so like a medical specialist or an orthodontist. And then tertiary care refers to hospital-based specialist services, so higher level services that are usually provided in hospitals or specialist centres. But again, these definitions are not rigid. There is, and you can probably already work out, there is some crossover between them, and they're generally just used as a shorthand to describe types of care. They're not necessarily completely prescriptives, and there are some forms of care which will cross over those systems. Now, just to give you a really brief overview as to where funding comes from health services, a lot of the ways that health is delivered is influenced by where the funding comes from and how that funding is then distributed throughout the system. So I think it's really helpful to understand the flow of money. But in the Australian health system, it is extremely complicated, just because the division of responsibilities between state and territory governments and the multiple providers across public and private sectors in the health system make it quite difficult to track where the money is going. But at a really simple level, you can see from this graph that the biggest funder is the Australian government. The next biggest, contributing at just under a third, are state and territory governments. And then the next biggest after that is individuals, and that's through co-payments. So co-payments for medicines, for a GP visit, for complementary medicines, those sorts of things, allied health. Health insurance is actually quite a small component, only about 9%. And then there's another smaller component, which is other non-government sources, which might include things like workers' compensation, for example. And on the other pie chart here, you can see that the bulk of the money goes through to hospitals. That is the biggest single chunk of money in terms of where the location of the health service. And the next most is primary health care, which would be, GPs, pharmacists, etc. And just to give you a quick overview of how funding is distributed across the different levels of government, one of the unusual, in some ways, features of the Australian health system is the way that responsibility is shared across state, territory, federal, and to some extent local governments. This is something that often causes problems when trying to coordinate across different sectors. So very briefly, the federal government is responsible for setting a national policy agenda. It's responsible for two big ticket items, Medicare and the PBS, that funds medicines. It also jointly funds public hospitals with state and territory governments. And it's also responsible for a few other discrete areas like community-controlled Aboriginal and Torres Strait Islander primary health care, and it's responsible for private health insurance policy and funding. State and territory governments, their main role is in funding, jointly funding, and they're responsible for the day-to-day management of public hospital services. They do fund some community-based and primary healthcare services that differs across state and territories, some preventive healthcare, and they're also responsible for ambulance services. Local governments have smaller role in healthcare, but they do provide some environmental health services and some community-based, home-based health services and health promotion. And there are a few areas, there are a few areas that have shared responsibility across those jurisdictions. They include health workforce, education and training, some regulatory services, and some funding of other health programs. So I just thought I'd spend a couple of minutes talking about just some of the problems that can occur through our very complex health funding system and why the system is the way it is now, and hopefully then to talk about what can be done about it. So I think in really simple terms, there's often no actual clear policy reason why some services are funded and some aren't, or why some are funded to a higher extent than others. They're often historical, they're often driven by particular professional groups. For example, the reason that dental care is not included in Medicare is because the dentists at the time opted out of Medicare for their own reasons. There is, within specific programs, there's often evidence as to how money is allocated within that program. So for example, within Medicare, for a service to be funded, it has to meet certain evidence standards of efficacy and safety, and same within the PBS. But there's not a lot of policy sense which guides funding across those programs. So to say, would it be better to fund this person to take an anti-inflammatory medication or see a physiotherapist? So there's very little flexibility in allocating funding across different programs. I think the other important thing to understand is that there are two really big uncapped programs. Uncapped means that there's no ceiling on the expenditure. It's just in response to demand. That's Medicare and the PBS. Because those programs are uncapped, that can really influence other government decisions and other expenditure. Often it means that governments can be reluctant to spend money in other areas because they're not certain about their expenditure in those two areas. And it can often mean that because there's uncapped, there's a bit more capacity to fund things through those mechanisms. So a lot of growth can get funded through, growth in demand can get funded through these two programs, which may not necessarily be the best place to fund that healthcare. So for example, it can be cheaper for a consumer to take an anti-inflammatory funded by the PBS rather than see a physiotherapist, for example. There's a lot of public and media pressure which can influence funding decisions, and that often focuses on hospitals and acute care, just because they can be really the pointy end and at an individual level very visible. So you probably notice a lot of media attention on hospital waiting lists, on what happens in the hospital sector, and it's much less, much harder to generate the same level of media attention on, say, preventative health, which can also drive governments to direct funding into those areas and mean that areas like preventative health and health promotion are underfunded. And another important thing to understand is that the cost shifting and complexity. Cost shifting means just sort of shifting costs around without actually delivering any better value, just to meet sort of budgetary means. So for example, within the hospital system, there are a lot of efforts made for the state and territory governments to shift costs to the Commonwealth and vice versa. And these sorts of things can make it very difficult to track where the spending's going and to determine whether it's delivering good value or not. Somebody asked about private health insurance. So just to give you a brief overview of that, private health insurance is a very problematic area of our health system. Even though it funds only 9% of health expenditure overall, it does take up a lot of policy and media attention. My feeling on it, and people have very strong feelings about private health insurance, so just to clarify where I'm coming from, I don't think private health insurance has a role within our health system, which is not to say that it's not for individual people a better option than what else is available at the moment. I think the problems with private health insurance exist because Medicare was introduced over the top of private health insurance. Private health insurance had been around prior to Medicare, and the role that it plays once universal health insurance system, Medicare, was introduced, that role has never been resolved. And I think there are some underlying tensions there to what does it mean to have private health insurance in an environment where we have universal healthcare and free public hospital treatment. Currently, it costs us around $6.5 billion in direct subsidies and just under double that in indirect subsidies. So it is a very expensive system to maintain. I feel that it's less efficient and less equitable than Medicare. It returns less in terms of actual dollars value in terms of services to consumers, just because the administrative costs are much higher. And it also has a very limited ability to control the costs of healthcare compared with Medicare. However, it is a very entrenched system. As I said, it's been around prior to Medicare, 100 years or more longer. It does solve some political problems for government because it allows the government to say that it is doing something to address problems like access and inequity and providing some assistance for some people, even though it does it in an inefficient and I would argue inequitable way. And it is strongly supported by private health providers as it provides an income stream to private hospitals and private healthcare providers. So it will be a very hard system to dislodge. One of your challenges might be to decide whether it's worth saving, and if so, how to do that in a way that meets consumers' needs, or whether it's better to advocate for complete reform. So finally, this is where you come in, and I'd just like to say yes, I thank you very much for getting involved with health policy and advocacy. It's a really important role to play, and I think it's absolutely vital that we have more young people involved. I think one of the first challenges is identifying what the problem is. So a problem with a health system can be at the systemic level, it can be at the service level, it can be a problem to do with a particular person. And I think identifying that is a really good first step, and understanding the health policy and funding environment can really help clarify whether the problem that you encounter is something that is a big picture systemic problem, or is an individual problem to do with, say, that service or a particular individual. I think another issue to look at is whether it's better to push for incremental changes or major reform. The history of the Australian health system is that major reform is unlikely and happens very rarely, and incremental change is much more possible. But some of our biggest and most successful health programs like Medicare and the PBS were major reforms, and they have tended to be very enduring. I think one big challenge is combating vested interests. Unfortunately, as I said at the start of the presentation, a lot of decisions made about health policies and funding are made in response to pressure from vested interest groups, and they tend to have a disproportionate influence over how the health system is organised and operates, and that is a big challenge. Some of the opportunities for change and reform happen when there's a crisis, and obviously at the moment we're experiencing one of our greatest health crises. So I think that is creating opportunities for change and reform, which I'd encourage you to look for. Another challenge is how to work within a short-term political cycle. Often the changes that are required to improve healthcare are long-term. In the short term, they can cause disruption, they can involve costs, they can annoy people. And with a short-term political cycle, that can be a real challenge. Governments often have an incentive just to keep things ticking over to the next election and not wanting to implement any longer-term reforms. I think building relationships and networks is really crucial in my experience to achieving change. So among yourselves, within your networks, and also using the media and advocacy groups, the supportive groups like CHF that have the expertise and experience in advocating to government and know how the system works. I think that's really important. And finally, I'd also really like to invite you all to become familiar with CROCI if you're not already familiar with that as a social journalism project. And we would really love to hear from any of you. We have a separate section for contributors, young people who are contributors. It's called CROCI Youth, and would really encourage any contributions that you are able to make about your experience or thoughts about health system reform, and would really welcome your input. So yes, if you'd log on to look at the website, follow us on Twitter, and get in touch with me anytime if you have any questions, or if you have anything that you've written and you'd like us to consider publishing it, we'd be really keen to see it. Thank you very much.
Thank you so much, Jennifer. That was a really great presentation. I know that a lot of some of the issues you've raised there have been things that have been discussed at previous Youth Health Forum events. I think there's a lot of interest and intent towards getting some more systemic changes to those entrenched problems, particularly around equity. So for our next session, we're going to be speaking with Stacy and Annette. Stacy and Annette are speakers who work with the Community Engagement section of the National Disability Insurance Agency. This is the department that manages the National Disability Insurance Scheme, the NDIS, which was launched by the Gillard government in 2013 and rolled out nationally in 2016. Although it's only been around for a few years, I'm sure all of us know someone who accesses or has been impacted by the changes in the NDIS system. And we've probably heard a lot about it in the news, especially lately. Like the other areas in the health system, NDIS can be a little bit difficult to see how all the parts fit together from the outside. So we're really excited to have Stacy and Annette here to tell us a little bit more about how everything works and where the potential is for individuals to get involved and influence the system. Over to you, Annette and Stacy.
Hi, it's Annette here, and I'm actually in the engagement team, and I'm based in Alice Springs in the Northern Territory. So I cover the whole territory and also the top end of South Australia and travel to all those remote communities, hoping to be able to improve people's lives with disabilities in all of our region. So Stacy actually has a presentation for us today. So over to you, Stacy.
Thank you very much. I'm just going to share something. Hello, technology. Bingo. Hello. Look, my name's Stacy Anderson. As Annette said, I'm with the community events team. First of all, I'd like to acknowledge the traditional owners and the custodians, which I'm in Newcastle, so it's the Awabika and Warrama, yes, hello, of the country in which we meet today, and their continuing connection to Lansing community. I pay my respects to the elders, past, present and emerging, and I would like to extend that acknowledgement and respect to any Aboriginal and Torres Strait Islanders here today. So, quick bit of stats. We, as Georgia said, we've been around for 7 years. We encompass the whole country. We work with children from 0 to 6, and then we consider then 7 to 65. After 65, people then are then part of the aged care system. So we've actually just reached the 400,000 participant mark, which is good. So we're really pleased about that. So it's still a growing area, and it's a very, very new organisation and a new area. So I just wanted to show you that we don't just sit in our desks and in our offices in Metropolitan, that we really do go everywhere. That's a lovely photo of Annette up in Alice in Morganton. So it's from Alice Springs. So we do really make the strong commitment to actually go out and meet people rather than just sit in an office somewhere. So the NDIS, when it was introduced, is actually a new way of support, and federal governments, and actually had a commitment and memorandum of understanding so that we could look at people who had disabilities and how we can actually best support them. So the key issue for us is that the participants, it's about meeting the participants' goals. So it's making sure that they have what we call is control. So they have control over what happens to them rather than the old welfare model of people who making decisions for other people, rather than the participants actually saying what their goals are and how they want to achieve those goals. So that was a really So we have an access. So there's a pathway. So there's actually a way that you can, and I'll get that, we'll talk about those in the end. So we've really gone out of our way to constantly change and shape our access so that to make it more easy. It can be tricky, but there are also people in the community, and we'll get to them in a minute as well, who are here to actually help you, as well as the NDIS itself. There are other supports within the community to complete the access process correctly, hopefully to get them in. So the requirements are your age. So as I said, so it's from age 6 to residence, your disability or developmental delay, and how that disability impacts your everyday life. So we look at more about the permanence of the disability, which I'll get to in a minute as well, can make psychosocial mental health things a bit of a challenge because of the episodic nature sometimes. So we also look at the outcomes of treatments which might reduce these impacts of your disability and any reasons why these treatments have not been explored. So the requirements, as I said, you have to have a lifelong disability. That's pretty much the fundamental one. You are unable to complete everyday tasks in at least one life domain as a result of your disability and without support from a person or specialised equipment, and your disability impacts your ability to work and your ability to engage socially within your community in a way that you want to do, not in a way that other people think you should, but in a way that you actually want to do. So you require lifetime support, which is most appropriately provided by the NDIS. So we have a thing called reduce functional capacity. So that's when I talked about things that impact and mean that you can't interact with your community or interact with in an economic sense, so work, university, any kinds of study. So as I said, the mobility is your ability to get around, and communication is your ability to speak, write and express your needs, and that's really important. So the social interaction, so the interaction with local community and making and keeping friends. So that could be your sporting group, that could be your local church, that could be a painting and drawing group. So it's those kind of things that are really important to people, those social interactions. So it's the learning, and it's the learning and practice of new skills. So for some people it can be going to university, for others it can be learning how to cook, how to do the laundry. We don't make any decisions and definitions about those things because it's about where that person's abilities are and what they want to achieve. So there's the self-care, so there's the showering and eating and dressing, and the self-management, which is making decisions about how you want to do things and making financial decisions about how your money will and won't be spent. So each system, this is where it now gets really complicated. Each system has different responsibilities. In the context of the NDIA and mental health, it's how the NDIA, mental health services and health support a person to get, so how we do it in a collaborative way. So the system, we've got COAG principles, which COAG published the updated principles to determine the responsibility of the NDIS and other systems. And if you're into policy, it's a fascinating read. Those of you who I suspect are all policy nerds, just like I am. So these principles cover 11 areas, including justice, health, mental health, housing, which have been agreed to by all Commonwealth, state and territory governments. So it's the way that we look and approach. So it's not a single approach, it's a collaborative approach. So an individual plan, which has an open, oh, that's gone. So your individual plan, trust me, is 3 ways. So you have access. After access, you have your agreed goals and aspirations. Then you have how your supports, your mainstream and community supports provided by family, friends and community. We talk I talked about sporting groups, etc. earlier, and then we come in with our funded support. So what are reasonable and necessary. So we fill in pretty much the gaps of things, but we only fund things that are in direct consequence of your disability. So that means we don't fund your rent, we don't fund food, we don't fund any kind of other support. So I'll start that by, so what we do support is wheelchairs, hearing aids, beds, prosthetics, home mods. So some people are quite familiar with home modification. So we provide personal care and domestic assistance, and with therapies as required of your impairment, including physiotherapy, speech therapy, and occupational therapy, but not the actual treatments. So now I'm going to, one of your questions was about mental health. So I'm just going to go into this a bit stronger because it is complex. So evidence of psychosocial disability form, but that's the form, because we're a federal government, so we love a form. So it assists in supporting a clinician to provide evidence of disability. So as I said, as part of your access process, you have to produce a whole range of documents, and we make this as easy as possible for people. So you can have something from your GP, you can have something from your psychologist, your psychiatrist, a mental health nurse. So any of those kind of issues, any of those kind of specialist clinicians can provide support for your evidence of disability. So we go, because I don't have much time, if you're interested, you can search our website, which has everything that I've discussed today. So if you search mental health in the NDIS, you get a much bigger picture and a much better understanding of what you need for access under the psychosocial. So we have responsibilities, which is we look at the ongoing recovery that supports and focuses on a person's ability, including those people with mental illness or a psychiatric condition. So we're looking to make sure that you can undertake activities of daily life, which we talked about earlier. So it's whether it's mobility, whether it's self-care, financial funding, or whether it's looking at making sure how you can progress in your own personal needs, or education and training. So it also supports to participate in the community and in social and economic life, which I've talked about. And it may also include family and carer supports to support them in their carer role. What the mental health system is responsible for is the treatment of the mental illness, including acute patient and ambulatory. And so the NDIS doesn't support those things because these are things that are found within the health system itself for everybody. So mental health services are also responsible for rehabilitation and recovery and early intervention. And it's the early intervention that's really important, particularly for the 0 to 6. Residential care, which is a housing issue where primary purpose is for a limited follow-up to link to treatment or a diversion from acute hospital treatment. Mental health facilities, as Jennifer talked about, are state and federal responsibilities, and the health or mental health system will be responsible for supports relating to comorbidity and psychiatric conditions where such supports are the responsibility of the health system. All right. Now, when I was talking about access earlier, I said there is a whole range of people out there to actually help you navigate the access process as well as the NDIS. But we have what we call partners. So the early childhood partners, as I said, they're for the 0 to 6. The LACs are called local area coordinators, and they were appointed through the NDIS through a tender process, as were the ECI partners. So that's how they got the gig, and they are pretty much allies and users at a local level. So what we know in the NDIS, our partners also know. So they really are, think of them as an extension of the NDIS, and they're usually your first port of call out in the community. And if there's something that they can't help you with, then they speak to staff within the NDIS. So you've got your LAC partners, you've got your ECEI partners, and you've got the NDIA itself. Now, they're for awareness, they're for making sure you know and assist with access. They run local community sessions. They also help connect the participant to other services, so all those other health services that I just talked about that aren't the responsibility of the NDIS. The LAC partners know where they are and can assist you with those. And they can also help you with your planning meetings. Now, planning meeting is when you get actual access into the NDIS. We then develop a plan with your goals in mind. So it's about what you can achieve and what goals you can achieve and how you want to achieve your goals. So then a planner, an NDIS planner, develops your plan. Yes, we try to use simple language. And then they will also support the participant to understand and implement their plan. Now, there's also another level to this called the support coordinator. And their role, you can use from your budget allocation in your plan, you can actually use it to hire the support coordinator. So their role, like the LACs, is also to help you with your plan and to connect you with the services that you may need, whether it's the best home modification organisation around, or it's some kind of therapy that you require. The support coordinators and the LACs are there to help you. So I guess what I'm trying to say is that we don't just give you, you get access, we give you a plan and then we send you off on your merry way. There's a whole range of support services that are also put in place to assist people in implementing their plan. Right. So we've had some, for the policy nerds again, like me, we've had some service improvements, they call them. And our Minister, Stuart Robert, announced those, actually it's only in the last 4 weeks. So we've got a service participant charter that outlines our commitment to our participants. We've got a service guarantee, which includes, we've improved our timeframes to make decisions, and that includes access and planning. An improvement plan, so that's getting the plan out for the NDIA over the next 2 years. And there's now a thing called independent assessments. Now, this is a bit of a contentious issue at the moment, the independent assessments. And I think most of the contention is about lack of information and lack of understanding of what we're trying to do with the IA. So the independent assessment is something that the organisation will pay for, so the NDIS pays for. And it's, whereas a lot of the disability things are saying what you can't do, the independent assessments are more about what you can do. It's looking at what you actually can do. So it gives the planners and the participant and their support an additional level of understanding while we're planning their goals. So instead of saying, well, you know, you're in a wheelchair, it's okay, you might be in a wheelchair, but you can still play netball if you so choose. You can still skydive if you so choose, because you've got certain other, the assessment will tell us what you actually can do. So it's an important step. Now, these independent assessments have come from our COAG, they've come from the sector, and they've come from our Disability Commission. So it's really, the independent assessments have been introduced as pushing and advocacy from the sector. So we didn't have a rush of blood to the head and thought it'd be a good idea. It's actually the sector that has said this is what we really need to add to the planning process. So it will start applications. So from February next year, if anybody's seeking access, they will get an independent assessment, and then all the existing participants, as their plans come under review, will get one from mid-2021, so around June, July next year. All right, I think we've just said that. So there is a YouTube video on the independent assessments. So as I said, the resources that supports you are and I'm just repeating this because I think these are important. For some people, there's a perception that the NDIS isn't. The NDIS, let me rephrase that, the NDIS is different to a lot of government agencies in that we keep talking to you, we keep supporting you. So we've got the partners in the community, which I discussed. There's a new program called the National Community Connectors, and they are focusing on culturally and linguistically diverse and Aboriginal and Torres Strait Islanders. So they're the people that may need access, but aren't sure about how to do that. There might be language issues for both of those two groups. There might be trust issues. So the connector's job is to go out and sit in community, sit in a mosque, sit in whatever in the community centre, and actually just talk to people and start to get the information out and be there and readily available to answer all their questions. So we've got an information linkage and capacity building supports. There are advocacy organisations, of course, and peak organisations, the same as yours. We're also looking at carers, so there's a carer gateway. We have events and webinars constantly. Our website is constantly updated. We have a YouTube site. So there are ways that if you're trying to find the information and you're locked down in Victoria and can't go out to your LAC, the website is a wealth of information, as websites should be. So also we have pathway booklets. Now these are in about 10 to 12 languages, I think. And these are very straightforward. They've been written in easy read so that you can follow them in a very easy way to actually understand. So you start writing everything and it will show you what you need what you don't have before we submit something for access. So we'll make sure that you've got everything that you need to submit to us and that we need to correctly assess your request for access. Now, there was also a question about governance. So if you're not happy with the NDIS, we have the Commission, the NDIS Commission, Quality and Safeguards Commission. You can make a complaint, that's fine. You don't have to go through the organisation itself. That complaint can actually just go straight to the Commission. So that's with our funded services, and that's a lot of our providers. If you're not happy with our actions or decisions, you can request, you can come back to us and you can request a review of your plan. And that's very sexily called an S100. So which will be section 100 of the Act. So you can quite happily, and I sit next to a lady who reviews these constantly, or you can talk to the Commonwealth Ombudsman, and there's both details there. Or if you're not happy with a service provided by another agency, you can talk to your state or territory body, complaints body, and we will give you those links for our commission, as well as if it's something that's about discrimination, there is of course the discrimination. For more information, please contact us. I'm a community, Annette and I are a community engagement. I'm community engagement NSW, she's community engagement SA. If you find that you need help with English or hearing impaired or speech, we provide those interpretations as well. So I think that's the end of it for me. Sorry, I know it's really complex, but I tried to make it as quick as possible. I'm going to and just to know that I will send to Caroline this presentation, as well as a whole lot of the other links that we've discussed. I'm going to stop sharing now. Oh, there's Annette. Is there anything in the chat? Is there anything anybody wants to ask me? Now is the time.
We do have a set of questions, and we've got our final sort of 10-minute block till we wrap up at 1. We've got questions both I think that will be great for Jennifer and that will be great for Annette and Stacy. I might jump in to start. I think these were things that were submitted to us prior to the session, but I might jump in with one that I think will be great for Jennifer to start with. If there are young advocates that are interested in staying up to date with updates and news about health policy, especially at the moment with everything changing so rapidly, where are good sources for reliable information that people can understand and digest easily?
Good question. Well, you should definitely read Croaky. That's a really good source. Twitter is very active in the health sector on Twitter. It does take a little while to sort of, like with any social media, to sort of get the feed that meets your needs and to work out who are some trusted sources of information. And I like Twitter because it really is a bit of a melting pot of sort of experts, clinicians, consumers, and does really set up some really productive conversations, but does take a little bit of work, I find, to get what you want out of it. CHF obviously is another good source of information and advice. And there are some other reputable sort of research organisations like the Grattan Institute that puts out a lot of information on health. The Conversation is another really good source of more sort of academically based information. So yeah, they're really where I would start, and yeah, see where that finds you. Often I think in health, people often have an agenda and they're coming from a particular area, particular perspective, not necessarily wrong, but just one that informs their perspective. So I think it's just really important, like with any sort of research or opinions, just find out who the people are, where they're coming from, see what resonates with you and aligns with you, and challenge anything that doesn't resonate.
That's great advice. Absolutely. Love that. A question I think would be great, both actually for all three of you, if you can answer it in a sort of rapid fire. We don't have too much time, but as professionals who work in advocacy and engagement, what advice would you offer young people that are going into an advocacy space for the first time, people that are getting involved in sort of program development or feedback? Is there anything that you think that everybody should just know as like a one best tip?
Yes, I have.
Yep.
Which is, no question is stupid or silly.
I love that.
Do not hesitate to ask anything that is worrying you, because London to a brick, there are 20 other people in the same room who don't want to have the same thought. So don't hesitate.
That's a great one. I think that's kind of the philosophy behind these webinars at the end of the day. Annette or Jennifer, do you have anything you'd add?
I was just going to add exactly the same thing. It's like, just ask. What's the worst thing anyone's going to say to you is no, can't help you. That is the absolute worst. But just by asking, it's going to open up your world to your knowledge and what your entitlements are, etc. So yes, please ask. And yeah, there's no silly question whatsoever at all.
Fantastic.
Yeah, I think that's great. I'd just like to add, I think it's fantastic that anyone's getting involved in advocacy and health system design and reform, because it is the best thing to do in the world. And one question I find really useful to ask myself if I'm in that sort of role is just to ask whose story is not being told, who's not in the room. It can be hard often to see who's not there. So I think just being really conscious about, particularly if you're in an advocacy role, because your role is there to represent consumers. But yeah, I find it really useful just to be really reflective about who isn't present and whose story isn't being told in that environment.
That's fantastic.
That's
and I think,
sorry,
yeah.
I wanted to add that it is someone else's story and not your own. So it's not your personal beliefs or anything like that. So please listen to anyone else's story and advocate for them. Yeah.
Those are all really, really great pieces of advice. So something that got mentioned, particularly in the NDIS section, mentioned the COAG, so the Coalition of Australian Governments. There's been a lot of changes in their decision-making structures lately with the COAG moving to the National Cabinet. Would any of you be able to reflect on, I guess, briefly what those changes have been and if there's any sort of known impacts of that so far? It is still fairly recent.
Annette here. If you've got any questions, I'm sorry. I don't have any off the top of my head that answers for that particular question, but certainly send it through and we can find out for you.
Absolutely. Jennifer?
Well, I'd just like to say the COAG process had, pros and cons. So it did bring a lot of the jurisdictions together, and it did achieve some things, but it was extensively criticised for being very bureaucratic and very bogged down in process. So the move to a national cabinet during the early days of the COVID-19 pandemic was seen as a positive in some ways, in that it could sort of cut through some of those bureaucratic processes, and that did have some advantages and can have some advantages. And I suppose the downside, and some things other people have been pointing out about it, is that it can also reduce transparency. It can reduce the input that different jurisdictions can have. It politicizes it a lot more. More's happening behind closed doors. Not everyone is getting as much input into that process. And a lot of the way it's going to work hasn't really been articulated yet. So it is hard to see what's going to what it's going to end up looking like. But from what we've seen so far during the COVID-19 pandemic, is that decisions are being made, quickly, often without scrutiny, and having, often not being the best decisions as a result. So I think one of the challenges going forward is to preserve what is good about the level of cooperation and commitment, and drive to get things done of the National Cabinet, but maintaining some of the transparency that was around in the COAG days. I don't know if Carolyn has got anything she wants to add from her perspective. She might have a different view.
No, I think that's pretty much what we've been talking about here at CHF as well.
Yeah, I think you summed that up very well. So just because we are short on time, I will do one final question for all of you. If you could sort of wave the magic wand and choose one area for health system reform, what would that be for you?
Mm-hmm. I'm happy to go first. For me, the one thing that would make a really big change, which will probably never happen, I think that consumers should have control over health funding directly. I think, that the more that, I've seen really a lot of so many decisions are made about who holds the dollars, and until you change that, it's really hard to get any other changes. So I think increasing consumer control over, the health dollars and where they're spent would be the biggest single change that I would advocate for.
That would definitely be a big shift. Annette or Stacy, is there anything that if you could magically change either within DAS or outside?
Apart from learning next week's lotto numbers for myself. Look, I agree with Jennifer about the fact that we effectively have a two-tiered health system in this country, with the delays through the public health system, and then the fact that people can jump the queue in essence with private health, or if they're self-funding. And what that means for the NDIS participants is that they are the vulnerable, and they are the ones who are the most struggle financially. And so this means that they have to wait for a lot of things where they really shouldn't have to wait, because they are our most vulnerable. And that would be my magic wand.
I think that's a really important area, absolutely. Annette, did you have anything you'd like to add before we?
I do, thank you. And I guess because my passion is about assisting Indigenous people living on their land in their own cultural areas, and it just seems that while we'll say all the words that we are offering a scheme to every Australian, regardless of their whether they're Indigenous or not Indigenous, or multilingual, etc., it just to me appears that we not really on the ground do we have enough assistance or finances to be able to help those people, most vulnerable people in our country, to me, and that's only because I'm passionate from that area, is our Aboriginal people living on community who don't have the medical access like the rest of mainstream Australia. And it really concerns me as to what will happen in the future if we continue down this path for our One Nation people.
I think all three of those are fantastic areas, and really some things that I think need a lot of work and will hopefully spark a lot of thoughts in our young advocates here today.
And they're quite similar, aren't they?
There's a lot of common themes. Equity and choice, I think, is some of the
helping our vulnerable participants.
Absolutely. So just, I guess, to wrap up from here for especially our attendees, if anybody would like to get involved with the Youth Health Forum, you can learn more about us from the CHF website, or to get in touch with Carolyn. Her email address, I think she's going to pop it in the chat now, but you can also find it on the webinar page that you used to register for today. We do have future sessions coming from our webinar series. We've got 3 more planned. They'll be fortnightly. We have a session on advocacy, so stories from people who've built really successful campaigns and had great results, and some tips for how you can do that or get involved in other campaigns that interest you. Effective communication, so particularly about working with the media, journalists, how to write strong opinion pieces, and how independent journalism will be looking in the future. And another session will be on using research to inform advocacy. So some of the processes behind the research process, ethics and data, and how we can use evidence to change health services and health systems. Thank you so much to everybody who's joined. If you have any questions following up, feel free to, again, get in touch with Carolyn. Hope you've enjoyed this webinar and that we'll see you at our future sessions. Is there anything?
Thank you, Georgia.
No worries. Thank you so much to our panelists for coming as well. We really appreciate your time.
It was a pleasure.
All right.